cover today. Today's session is going to be primarily focused on two things. The first is we'd like to walk through the infrastructure development checklist. We would be very appreciative if the groups represented on the phone today would be willing to speak a little bit about their experience walking through that document. We're going to talk about each of the sections individually, as well as present some of our experience and best practice in these various areas. And then the second thing we'll be doing is discussing the case study. And the case study was designed to provide you folks with a real-life example of the types of environmental factors that safety net providers are facing. Of course, this is one specific example, and it is a real-life example. So we'll be able to speak to some of the actual response that safety net providers in this particular market undertook, as well as talk a little bit about some of their early successes. But given that the majority of today's agenda is really focused on us interacting with you folks, we would, again, very much appreciate if the folks on the phone would be so kind as to actively participate in today's conversation. I'm going to start by talking a little bit about some of the feedback we got via the SurveyMonkey response tool. We had asked folks to complete that tool after reviewing their infrastructure development checklist, but also to answer some of the questions that were posed at the end of session 4. In terms of the responses we received, some of the feedback that we got was that there really is an opportunity to begin to identify your gaps now, even if you're not necessarily moving forward directly or aggressively towards development of a network. Certainly there are some pretty clear examples of the types of capabilities that networks will need in order to operate in support of safety net providers under value-based payment models or other health reform models. And because it's relatively clear what some of those things are, there's really no sense in waiting necessarily for your state or the managed care players in your community to make some sort of move towards new payment models. And this is a point that I added that I think is really important to understand, which is that taking the time to understand and identify gaps you may have now really puts you in an advantageous position for seeking other funding sources as they become available. Just an example or a handful of the types of funding sources that make sense under this model that have rolled out just over the last few months would include the Health Center Control Network funding. The Health Center Control Network funding is typically made available only to federally qualified health centers, and we know that we have federally qualified health centers represented in the group, but that not everyone would be eligible for this funding. But that's funding that can help support various information technology and quality improvement initiatives that could theoretically serve as the backbone or underpinnings of a contracting or non-contracting network of safety net providers. Another example is any of the funding that's beginning to roll out now to support providers in achieving the goals of MACRA. And MACRA is a new Medicare payment initiative that essentially attempts to move virtually all providers who accept Medicare into some form of alternative payment model. And in doing so, virtually every provider operating within a safety net may be impacted by the changes that MACRA brings. MACRA is relatively new, and I'm sure you'll be hearing a lot about it over the course of the next several months, but there are funding initiatives around providing technical assistance under that model. Unfortunately, this year, Medicare did not offer a ACO investment model funding opportunity. They did offer that in the previous year's application, and that particular funding opportunity offered up to $2 million for networks that came together to operate under a Medicare Shared Savings Program contract. And we're holding out some hope that there may be a future round of that funding available. If if you take the time to identify the type of infrastructure you would desire to have, it makes evaluating these various funding initiatives much easier, and your response to them much easier, because you've already done the work to identify the kind of things that your organization might need. We asked as well for some suggestions for areas where specifically folks felt there was value in exploring collaboration. And not surprisingly, two of the responses we received had to do with health IT, or information technology, up to and including potentially sharing an electronic health record across multiple safety net providers. But there's a lot of other examples of health IT sharing that can occur across safety net provider settings. These include the use of telehealth as an opportunity to expand access, particularly in rural communities where it's hard to reach patients in person. This can also include data analytics, claims data evaluation software. These are fairly expensive undertakings, and typically there's considerable financial motivation to work across organizational boundaries when approaching these initiatives, because you can essentially reduce the total cost of ownership and provide opportunities for collaboration across care settings. A third example was standardizing clinical documentation so that even if you never intend to move towards more consolidated electronic health record systems, at least you can create some of your own standards for how electronic health record systems are used to capture certain information. And this doesn't suggest that we would replicate the work of other standards-making bodies, but for example, we may as a community decide that we wish to track certain metrics a certain way, or we wish to capture certain information such as health risk assessment screening tools consistently across provider organizations. And this might put us in a position in the future to leverage payer contracts or contracts with our state for providing those types of services, health risk assessments, care coordination, et cetera, at a greater level of scale, because we're all doing something in a very similar fashion. And the last example that was provided was the sharing of providers, especially hard to find specialists. And I know for a fact that some of the folks in this group are actually considering ways to potentially explore how to leverage scarce specialist providers across their various organizations, because it's very challenging to meet the needs, particularly of smaller communities who may not require necessarily full-time access to certain specialists, but do have specific needs for certain specialties in the care that they provide. I'm going to turn it to the group now and ask, were there any other thoughts regarding last week's session before we move into the infrastructure development checklist?
Angie, this is Beth. I don't have any questions, but I think the content from last week was very helpful in having a framework for when we are ready to be at that stage. So thank you for providing it.
Excellent. Okay. Any other thoughts from the group? Today's 100% discussion, so don't be shy.
This is Kendall with Kearney County Hospital. And one thing that we thought about as far as on the checklist that I don't see and don't remember seeing either was about potentially a shared board. If like for instance, we are considering applying to become a FQHC, and it was suggested to us to maybe reach out to other regional hospitals to form a partnership as we apply for that. And but then that would require a shared board, and we started to think about that, and that the additional complications that would potentially create versus us just needing, if we applied by ourselves, just adding 2 additional board members, which we've already done. It made us have to kind of rethink some things, and what, feeling like it would take a lot of additional work, but probably a lot of additional time as well.
Sure. I think that's a great point, and I think it's a pretty good segue into the infrastructure development checklist, because the very first item is about new entities. But I think that, as we've been doing this work over the last several years, one of the things that really jumps out to us is the importance of local governance, but also potentially new entities that allow for essentially novel governing bodies that represent a broader community. For example, and we'll get to the case study, but in the example of the case study, it was seen as very important that there be a distinct entity to serve as the contracting body, and that entity therefore needed essentially its own governing body. In your example, creating a federally qualified health center would require essentially a local governing body, and your point is that maybe that's something we should be looking at doing a little more broadly than just within our own organization. And I think that's a very good and important point. Another thing to think about, I think a lot of organizations are coming to this conclusion, particularly those that are working a little more aggressively or a little ahead of the curve. But one of the things that they're discovering is that even though their designation as a safety net provider has certain key advantages, there are also certain things that they just aren't allowed to do as the result of being that particular type of safety net provider. Rural health centers, for example, can't house certain capacities. Federally qualified health centers struggle to find ways to add specialty services because it's often considered outside of their scope. And the use of new entities is certainly a way to look at, overcoming some of those obstacles while also addressing the primary need in the particular community that's looking to address them. So it's absolutely a topic that's emerging, and I think one that's very, very relevant. And we'll explore a little bit more when we get to when we move into the infrastructure development checklist. Any other questions or comments before we look at the infrastructure development checklist? Okay, so we're going to take a look at the checklist. I want to walk through each of the sections, talk a little bit about what we discussed last time, and then kind of try to come to some best practice or conclusions around how we've seen organizations tackle these challenges. The first item on the infrastructure development checklist does actually deal with new entity formation. And some of this checklist is modeled very specifically after the CMS Medicare Shared Savings Program requirements, not because we think every organization represented here today might wish to ultimately form that type of entity, but because we've seen it serve as probably the best benchmark for what a network needs in order to be considered fully operational as well as clinically and financially integrated. And one of the things we discussed in terms of the definition of clinical integration is that there needs to be a formal organization or entity that represents the integrating body if you wish to go out into the market and contract for services either with managed care plans, directly with the state, with Medicare, or with commercial insurance companies. And many times it's been our experience that safety net providers don't have in-house expertise in this area. Some do, but not all do. So I'm hoping folks can talk a little bit about, in terms of kind of walking through this, is this an area where you feel that you have expertise, or is it an area where you felt as if you would need to look outside your organization to get the support that you need. What would be the plan for addressing that gap? Perhaps the folks with the Mississippi Primary Care Association can talk a little bit about this. I know that you worked with your members to create several new entities. Can you talk a little bit about the entity formation process? Who handled that? Was that internally done or externally handled? And what were some of the lessons learned?
Sure. This is Janice Sherman here in Mississippi. I wasn't here when we have an IPA that's been structured as a legal entity to handle some of our movement in this area. And I wasn't here when that was set up, so I'm going to let Joseph talk a little bit about how that was formed, and then I'll jump back in after that.
Yeah, so we did, most of that was handled in-house and just with our board of directors involvement, and then we did get some outside legal expertise, for our legal filings, and anything in the legal realm was outside of our organization. And there's really not a whole lot to say about it because it really was just set up as a shell. It really wasn't set up as fully functioning and as fully structured. It was just set up as that shell so that our members could participate in our Medicare Shared Savings Program, ACO.
Okay. But there was, it's a freestanding entity, like you mentioned, and you mentioned that
it is. It's not. It's the Primary Care Coalition of Mississippi, so it's an LLC that's a freestanding entity. Correct.
Okay, great. In terms of our experience around best practices in this particular area, we found that most organizations have, obviously worked with some local legal counsel historically, and whether or not that work has been centered around new entity formation, that someone who operates in your local market that also understands your organization reasonably well because they've, essentially served as legal counsel for you over time is usually pretty well equipped to address these types of questions and issues and even potentially do the work on your behalf. That said, as we'll talk about in the legal support section, there are certain very specialized skills or legal skills that quickly come into play that not always, we don't always find that maybe the lawyers that you've been working with historically on, maybe HR-related matters or, other legal matters may not necessarily be experts in that area. So it's important to understand that from the standpoint of forming a new entity, doing some of the initial legal filings, those types of things, oftentimes local counsel's probably best equipped to do that. They'll understand your state-specific laws. They'll know who you are as an organization historically and what you're trying to accomplish. But that may not be the only type of legal expertise that you need. The next set of infrastructure revolves around financial controls. And this includes banking relationships, financial policies and procedures, and even just basic accounting services. Can anyone speak to their thoughts on how to initiate that type of infrastructure to support a network? Okay, I'll speak to that one then. In terms of some of the basic financial controls, oftentimes what we find is that this is a great opportunity to subcontract back to one of the founding entities. So even if the network ultimately will maintain its own banking, maintain its own policies and procedures, and do its own, essentially require its own books, that that often we find that these are things that can be handled by qualified staff either at one of the safety net organizations or at a representative association. So in many cases, for example, an IPA formed of safety net providers might put a subcontract in place with a statewide association to handle the development and formation of policies and procedures and to oversee the creation of the banking relationships, as well as doing some of the basic bookkeeping, accounts payable, accounts receivable. Oftentimes this is done with a very specific contract in place for those services, as well as with compensation back to that association organization, because it helps keep the like a clear line between work done on behalf of members in other areas and work being done specific to the network. Particularly important if the memberships vary. So, for example, if your organization, and I know we have a couple here today, represents an association, the members in a network like an IPA may not 100% overlap with your association membership, and therefore having clear delineation of work being done for the network is relatively important. If you're a freestanding medical provider, and I know we have groups there, and you're thinking about creating some type of network with other freestanding providers, oftentimes what you'll find is that one organization's willing to provide these services to the new network, but again, doing so through a formal contractual relationship we consider to be fairly important, so that it's clear the level of effort that's being applied, as well as the level of effort being applied, as well as the any compensation that will be made to that one of the organizations participating in the initiative. The third bucket revolves around some of the more comprehensive legal support that's typically required, and we've provided a couple of examples: developing participation agreements, developing the service contract that I just discussed, as well as negotiation with health plans. That's not always a function that legal services or legal counsel will provide, but often is, and certainly review of any of those payer contracts is something that we would recommend be undertaken by qualified legal counsel. Can I ask, has any group represented here been involved in either developing or evaluating a Medicare Shared Savings Program participation agreement?
Andy, this is Janice again in Mississippi.
Yep.
We are currently, our FQHCs are currently in a Medicare Shared Savings Program through that particular IPA structure that we just talked about. And, evaluating the contract for that, it's more than a notion. I mean, it really, the aspect of how the expenses are allocated versus, what actually drills down to shared savings is an ongoing learning experience. And, there's something in the literature that I've been looking at, a lot of information out there about shared savings is, unique to each entity per se that, operates MSSP programs. So, it's an interesting dynamic to figure that piece out, but we're still working through some of that.
Okay. So for many safety net providers, this is the first time they've entered into a financial agreement with other safety net providers in which their take-home pay is influenced, in essence, by the performance of the whole. And creating a participation agreement is a particularly challenging exercise, I think, to your point, because it really does spell out the obligations and expectations of each of the individual organizations to the whole, to whatever the network is, and yet it's a very fluid and kind of always changing dynamic. You don't necessarily know how much savings is going to be available at the end of the year, what your total budget's going to be. And so it's a particularly challenging aspect of network formation is figuring out how to divide up a pie, particularly if you don't know how big the pie is going to be. So this is definitely an area where we've seen folks engage, particularly qualified legal counsel to help really understand those dynamics and make sure that something is created that's both fair, to the extent possible, and as well as extraordinarily clear, so that there's no risk or chance of, essentially misunderstanding or misalignment when the time comes to actually evaluate how to distribute funds to participants. I'd like to ask a different question. I'm sure every organization represented has some experience evaluating individual payer contracts. If you decide to delegate contracting to a network, of course, then that network would really be the one negotiating and evaluating contracts. Can an organization, is someone willing to talk a little bit about how they evaluate and negotiate contracts today, whether they do that in-house or whether they bring in expertise to assist them?
Andy, I'm going to jump back in again. This is Janice again, because I just did some of that this morning. And so we're at a stage where we're actually exploring, whether we need to do it in-house. And I know ultimately we will get some outside help for that, outside expertise.
Right.
But this morning I had an opportunity to start reviewing some of our FQHC contracts with the payers. And fortunately, one of our FQHCs participates in 2 other states. So I'm looking at the same payer with 3 contracts in 3 different states, and they were very different.
Yeah.
And so for that reason, I know that we'll be, we're actually meeting with some folks in Chicago regarding payer negotiations and contracts and all that. But just in terms of an initial look at them here internally, there's some real challenges there. And,
right.
What you do after you find that out is the question, because the FQHC in particular who shared those with me said that she had presented to the payers that the contracts were different, based on the state, and they're not responding to that.
Right. Okay. Yeah, I think it's one of the big advantages of achieving a level of integration is that you can start to look at those things much more granularly, and then apply your leverage to which, essentially try to standardize those. If you accomplish nothing else, if you don't end up getting, more upside in your contracts, if you accomplish nothing else than simplifying the existing terms of those contracts, you've essentially accomplished something pretty valuable to your members. So it's frustrating and challenging to kind of go through that process, but I think after going through it once or twice, you really start to see the value that a network can bring to a membership. There's a question that came in over chat that I'd like to address, and it has to do with rural FQHC networks. How do they find the legal counsel with the sophistication to navigate these participation agreements? I think the answer to that might have to do with looking maybe outside of your market or even potentially outside of your state. And I know that we like to work with counsel that we have experience with, that's close to home, and that has a very solid understanding of our state and our state laws. So when I mentioned earlier that when you're doing some of that initial entity setup work, that you really should try to rely on somebody in market who understands your state's specific laws governing corporations and LLCs and nonprofits. But oftentimes, if you can't find someone that has this particular experience, it is actually best to look to supplement that initial legal work with somebody from out of market. I'll give you a very concrete example. An organization came together in one Midwest state to form a integrated contracting network. They used local legal counsel to set up the initial entity. That same legal counsel had experience negotiating with the very managed care plans that operated in their state, so it was a very good fit for them to continue working with that organization. When a group in a neighboring state tried to create the same relationship, they utilized local legal counsel to help them get their initial organization structured. But when it came time to do the negotiation, they actually contracted with the same firm that the first state used. And the reason was because the managed care plans operating across, in both of those two states, there was a fair amount of overlap. So even though they had to bring in counsel from outside of their market, that counsel had experience working specifically with the types of payers that they were going to be, negotiating with. As it relates to the Medicare Shared Savings Program, I think there are now examples throughout the country of legal firms, legal counsel that have experience developing those participation agreements in a variety of different geographical markets that aren't necessarily going to be in your market, but that really do have the expertise to assist you. I'm going to move to the second page. I'm going to quickly go through services, and this relates to insurance. It also relates to some of the basics of making a network operate and work, and this includes administrative support, even things as basic as teleconference capabilities and administrative support. A couple of these things, are relatively easy to source, but it's amazing when groups first get started how easy it is to overlook the importance of some of these things, particularly things like teleconference capabilities. We've had groups run up pretty large teleconference bills, not realizing that they had options to look elsewhere. We have had a lot of groups that underestimate the importance of acquiring D&O, or Directors and Officers Insurance. You will have a board and committees and officers for this business, and it is typically our recommendation that you evaluate a D&O insurance package as a way of essentially protecting both the organization and those individuals. Administrative support oftentimes is subcontracted, again, either to an association or to one of the individual members, up to the point where the network has enough revenue and business to justify essentially maintaining its own dedicated staff. I'm not going to, people can feel free to ask questions or comments on that one, but I'm going to keep us moving. One of the big ones really does revolve around data and IT, and the two or three really most important ones and frankly most expensive ones include the ability to aggregate clinical data for reporting, as well as the ability to utilize claims data from the plans to better understand the patient population. These are, I wouldn't go as far as saying required, but we've never seen a group of safety net providers form a network that didn't have some capacity in both areas. The third, probably most important on this list, is tools for population health management. So literally the ability to track the type of interventions that the network takes or the individual organizations take in terms of attempting to improve the health of the underlying population. And quite frankly, that could require some level of health information exchange or patient portal, or essentially patient-facing technology in support of those goals. Can anyone comment on what they saw as some of the most pressing needs for shared data infrastructure? It came up a lot in the feedback we got on the homework assignment. So I'd love to hear if one organization would like to speak to some of what they see as the most pressing need.
Well, this is Kendall with Kearney County Hospital. While we're not really far into the process or anything on that order, I think something that we're aware of is that some providers are rely much more on data and use that successfully, where others don't do a good job of collecting data, or they're collecting data that really doesn't support a lot, just to be collecting data. And so I think a couple of things, making sure you have the right partners, but then identifying the most appropriate data and best tools for collecting that and getting everybody up to speed, basically.
That's great. And I think that's an important element of readiness, is really understanding where folks are in terms of the variation in their ability to collect and use data from their own systems as well as from external systems. That we'll get a little bit into that in participation criteria, which is the next set of infrastructure needs. But from this standpoint, I think you're right. I think most successful groups have found that either building internal capacity or essentially contracting for external capacity to assist them in understanding how big of a gap they have across their membership in terms of the types of data they collect and how they use it, as well as turning that into meaningful information. And like I said, we've seen groups be very successful building that capability in-house. We've seen other groups be very successful really making that a kind of a cornerstone of their relationship with a third party to come in and assist them in doing that work. But yes, very critical. Again, the ACO program, Medicare Shared Savings Program, is a great benchmark for this. When you apply to operate as an ACO, you have to submit a narrative specifically indicating how you're going to use data both from CMS as well as from the participating organizations to drive improvements in population health and care coordination. So it's very clear that this is an important part of what networks do as they work on behalf of the patients that they serve. We had a little bit of a conversation of the implications on participation criteria, and generally speaking, as we mentioned in the last session, actually it might have been 2 sessions ago around clinical integration, it's really essential to have a set of participation standards and criteria, both because it gives the network a value proposition for when it goes to contract with plans, as to why the network offers advantages over other providers that are not participating in the network. But the other reason participation standards are important is because it's an important litmus test from an antitrust standpoint as to whether the network is in fact creating value in the community that it's operating in. We've seen groups over-engineer these, essentially trying to create a very, very high bar and standard, when the reality is most groups would benefit from starting with what they're capable of now, and then over time layering in new standards that align with the goals they've set for the population that they serve. Does anyone have experience creating participation criteria for a network like this, essentially standards of operating? Okay. As I mentioned, I'll just give some of our observation. The things that are listed here are typically good starting points. So what are the currently collected, if you already have some type of program to evaluate clinical measures across your organization, that's a good place to start. Things that exist within the meaningful use attestation requirements are a great place to start because those demonstrate shared values and shared goals within the organizations. If your organizations get recognized as patient-centered medical homes, certainly there are some kind of some low-hanging fruit within those requirements that theoretically can be used as participation criteria. We often recommend that there be some kind of financial adequacy or sustainability transparency and reporting amongst network members. because the network and its members need to know that its partners are essentially financially solvent. And there may be certain operational measures as well that you wish to bring into the fold. Very quickly, clinical leadership and clinical programs. Regardless of the type of network that you form, and regardless of whether you ultimately try to achieve clinical integration, we strongly recommend that there be a clear clinical leadership function within the organization. Typically, this takes the form of both a chief medical officer as well as a clinical committee to get input from a broader set of physicians, nurses, nurse practitioners, social workers, really anyone representing the kind of clinical makeup of the organization, and that these groups should be focused on moving towards more standardized clinical programs. That was one of the things that came up in the feedback was, can we do some standard documentation? Can we look at ways of essentially becoming better or more consistent at certain things that we do across our organizations? And we think this is, pretty important, again, both from the standpoint of being able to achieve the type of incentives in the type of contract that you'll sign, but also, and equally important, in demonstrating that the network is adding value from a healthcare improvement standpoint that ultimately is a protection from, for antitrust issues. Joseph, I wondered if you could talk, because the ACO that you guys worked to form, you guys have had, I think, some pretty good success. Can you talk a little bit about some of the things clinically that the group decided to do?
The QICC, yeah.
Yeah, so we have a clinical committee. It's called the Quality Improvement and Care Coordination Committee, and it's built up of clinical people from the health centers. It's chaired by a medical director at one of the health centers, and so a lot of initiatives are driven out of that committee that are clinically related. And as you were talking, I was just having a sidebar with Janice, and that I really think we've done a lot to create this structure of having that clinical piece built into the organization. But I still think we have a little ways to go to drive the engagement of just really getting those clinical staff members in the know of what we're doing. And we have, aside from the ACO, Dr. Fuqua has a QI work group that's completely separate, but I think it really functions well, and there's lots of engagement within that committee. And so I would like to see within our ACO, our QICC committee, I would like to see that type of engagement, and I think we're getting there. We're in year 3, and we've signed on for renewal starting in 2017. So I think every year we get more engagement, but that's definitely the next step of really getting things moving forward.
And I'm gonna piggyback on what Joseph said, Andy. I think, too, as we move forward with really building a true infrastructure for the IPA, I've really been talking to folks, particularly physicians, about potentially having someone on staff, because with IRIS, the association is an integral partner, and so we're also working with the HCCN to try and, bridge all of these things so that we really do build a strong network at the state level. But we really need we need a physician that's not juggling between seeing patients, and that's part of the dilemma with the FQHCs. I mean, I know we're moving out of the volume-based world, but they're still having to see patients, and so there's really some limitations there. And if we had somebody on staff, which would really pay for itself, I believe, then I think we'd get a lot stronger a lot better positioning in terms of clinical leadership. So that's my plan.
Yeah, I think you're right. I think there is that point at which you kind of outgrow the ability to tap, partial resources here and there in pursuit of clinical improvement, and where you really do need to look at having dedicated leadership and time. And, it's interesting, there's a lot of models, private model, non-safety net models, where they wouldn't, whether it's IPAs or ACOs, they wouldn't dream of trying to do this work without dedicated clinician leadership that's really focused on the overarching problem and not, seeing patients 32 hours a week and hopefully being able to provide 8 hours a week to the network. So,
right.
I'll skip the consulting services. I want to get into the case study. Any other questions before we move into the case study? Okay. The way I'm going to approach this case study is we're going to go through each of the environmental factors. I have a slide for each environmental factor. I want to make sure folks understand them. And then I'd like to talk about that factor a little bit. I will, again, be asking for participation. I particularly am interested in folks who are operating in maybe a similar environment, talking a little bit about their experience. And then we'll save some time at the end to talk about some of the discussion questions, which really were designed to look at all of the components essentially operating together. This is a very real case study, although we've taken the liberty of introducing a couple of nuances from across a few examples of very real networks operating today. And I think it's important to understand that we made some decisions to highlight certain environmental factors. Your environmental factors might be different, and that might require a slightly different solution. However, this was the best way we could come up with to really get you thinking about how your environment is impacting essentially the need or the desire to work more closely together. So don't hesitate as we go through this, if it doesn't look like the model that's evolving in your state or region, to let us know, and we can talk a little bit about how it might change the impact on what's going on. So we're going to look at this through the framework of kind of 6 components. The first is the overarching environment. The second is what the group of safety net providers did in response to that environment, how they formalized it, who they had to go through essentially to get contracts, what infrastructure they needed to essentially make it work, and then what they did essentially to achieve their goals, which creates both sustainability for the network and ideally renewed or new investment in the underlying safety net providers. So in our particular case study here, we've identified a state that's decided to not only expand its Medicaid plan, but to also push the overwhelming majority of Medicaid patients into private managed care organizations. And in doing so, enrollment for patients in managed care organizations was considered to be mandatory. The state intended to implement financial withholds, which means that the managed care plans had to achieve certain levels of clinical performance to get essentially all of their money. And so this puts a pretty high burden on them to select providers that are more likely to help them achieve that goal. And the MCOs, the managed care organizations, were required to make a good faith, I should say good faith effort, not good faith estimate, a good faith effort to include essential community providers, of which most safety net providers would be included in that category in all regions of the state. So in essence, they're saying you really need to contract with the safety net in order to do this. This is a pretty common model. This is a model that we've seen evolve in many states, and really, while we don't think is what's going to happen in virtually all states, we think that some flavor of this is fairly likely. What some of the nuances might be is that a state might have a historical managed care program and simply look to expand upon it, or the state might be creating a managed care program for the very first time. Is there anyone on the phone that wants to talk a little bit about how this relates or doesn't relate to the environment in their marketplace?
Andy, this is...
Hi, this is Jason Dunn at Jordan Health. This is essentially the New York model.
Yeah. Okay.
The Department of Health has made it clear that they do not want to be in the Medicaid business, but instead plan to provide primarily on a capitated basis, plus payments for value-based incentives to the managed care companies, with everybody moving into managed care.
Okay. Can I, I'm sure you've had some time to think about pros and cons. What's your top pro and top con of a managed care infrastructure like this?
We have a heck of a time thinking of a top pro.
Okay.
The challenges that we see in this are severalfold. One, to the comments that were made earlier, just capturing the data that are needed to enable us to understand how we're performing, how our region is performing, and how the state as a whole is performing against the outcome metrics.
Yeah.
Having a vehicle to combine claims data plus EHR data, that's probably one of the biggest ones. And the other one, which really resonated with me as I was reading the case study, if I didn't know better, I would say the New York State Department of Health was endeavoring to force all independent primary care providers into a hospital system.
Yeah.
So ultimately, the hospital systems will be running healthcare in New York State. And for an organization like Jordan Health that serves a population that historically has been ignored by the hospital systems and which is split between two hospital systems, that's a pretty scary thought.
Yeah, yeah. And we're going to hit on that a little bit later. The red box all the way at the end is safety net providers really seeking an alternative to being forced into health system-led networks. And we want to explore that because this network response is, as much as anything, what we feel is our best bet to be an alternative and to have an alternative, essentially, between that. I think someone else wanted to speak as well. I want to hear that, and then I'll reflect a little bit on these thoughts.
Andy, this is Beth. And while this doesn't look exactly like New Mexico, some of the beginning steps do. We're an expansion state, and our 1115 waiver started at the exact same day as expansion. So 77% of our population, of our Medicaid population, is in a managed care organization. I think a couple important differences are that there is no hospital system centric view, number one. Number two, every MCO is required to demonstrate network adequacy, and it's not a good faith effort. They must have it. So that creates, in theory, some leverage, not enough, for all of the safety net hospitals in rural and frontier New Mexico to have access to the plans. So, and there is no carve out for age blind and disabled. Ellen and Christine, what would you add to that?
Nothing from here, Beth. This is Ellen.
Christina, do you have contracts with all of the MCOs?
Yeah, we do, and as well as the challenges that go along with them, with the MCOs. And then again, there's 3-4 MCOs in the state that do Medicaid, so I mean, it's not like much choice. And then the contracts that we get from them are almost identical.
Right, they're pretty nasty with their contracts, but they're required to contract with you.
Right, and that's supposed to be some of the leverage that we have, that we could say we're not gonna take what you give us. because they are required since we're essential providers out here, we're sole providers in our areas. But none of us has really had the wherewithal to stand up and do that.
Right. And then Andy, another difference is that they are required, of course, to have this care coordination model and do these health risk assessments, and the frequency of them and all this stuff varies by the acuity of the patient, and I'm forgetting all the important language that Ellen knows on it. But they are not required to have be within 50 miles of their patients. So they are literally hundreds of miles from their patients, which is obviously why we're working with you and trying to figure out a way to mitigate that gap.
That's right. Yeah, I kind of threw that curveball in there for you, Beth. That 50 miles, within 50 miles of their care coordinator.
Yeah, I bet Christina chuckled at that.
Okay, let's. I'm going to move to the ABD, and then I want to circle back and talk a little bit about some of the what we see as pros of managed care. I know it's people may be feeling like there's not a lot, but I want to offer some hope. But we did kind of introduce a little bit of this next concept. So this particular state had a very specific interest in reducing costs in the age-blind disabled population, and actually forced the managed care plans to create a funding mechanism for local care coordination. This care coordination was risk adjusted, such that depending on the severity of the case, the panel size of care coordinator to patient ranged from between 1 and 200 for very high-risk patients to 1 in 1,000 for medium or low-risk patients. Not a lot of low-risk patients in the ABD population. And they had a goal of really trying to house those care coordinators locally as much as possible, to the extent possible, because they saw value in those care coordinators really being able to, at some point, maintain a level of face-to-face relationship with a particular patient. This is essentially one of the few areas where we do see some pros to managed care for safety net providers, because in situations like this where special care coordination models are necessary, our organizations are historically the ones that are located in those particular markets. Remember that capitated managed care, private managed care, does in fact reduce some of the restrictions. The state no longer necessarily maintains a single fee schedule and dictates what will and will not be paid for. In these models, the managed care plans actually gain a lot of clout. And I think what you'll find is different managed care plans have very different approaches to how they engage with providers around these. Some are very forward-thinking and want to house all of the care management services within your organizations. And others really come in with an approach that they know best, they know how to deliver it, and they'd much rather just pay you on a basic fee schedule and use their care coordination capacity. Anyone operating in a market that has a special program for a special Medicaid subpopulation?
Andy, I'm sorry, would you repeat that question?
Is anybody operating in a market that's created this type of special program for a subpopulation of the Medicaid overall population?
We do have subpopulations here in Mississippi, but the care coordination component is not a part of that. For the age blind and disabled, there's they've been carved out of managed care. And are actually, supposed to be directly addressed under special initiatives, but there's no incentive for that. They're just not required to be in a capitated program.
I see. Okay. That's historically that's been the response of states, is to say that managed care is really for the lower risk populations, lower cost populations, to just handle those populations on behalf of the state. But we're seeing that attitude change. And I think the primary reason we're seeing that attitude change is because ABD and other special populations really do represent one of the bigger potential savings opportunities for the state. So whereas historically patient advocacy groups were very opposed to the idea of moving these special populations into capitated private managed care, we're seeing a reduction in that resistance, and frankly, a lot of states moving forward and creating opportunities for them to be in managed care. It is an excellent opportunity for safety net providers to partner with those managed care companies, because those managed care companies are getting fairly sizable budgets to address the special needs of these populations, and have reduced restrictions to create unique relationships with providers of all types, but in particular with safety net providers who are currently caring for those populations of patients. So in this particular case, and we're going to talk about kind of how they responded, how this particular group responded. But in this particular case, they were very proactive in approaching the managed care companies that were bidding for a contract with the state, and actually were able to articulate a clear plan for what they wanted to do. They wanted to hire the care coordinator, use the existing care coordination capacity they have, hire additional care coordination capacity, house them in their clinics and facilities, and be paid out of the capitated payment to the managed care plan. They wanted to be paid on a per member per month basis to provide certain care management capabilities or certain care management services to the age-blind disabled population. Any other thoughts on this aspect of the plan?
Excuse me, this is Kendall with Kearney County Hospital in Lincoln, Kansas. And we are looking to contract with we have 3 MCOs, though our state obviously isn't one that's expanded Medicaid. But we're looking to contract with the 3 MCOs, and in fact signed an agreement with one yesterday that would help us build infrastructure which would include hiring a care coordinator because they see value in that person being housed with us around high utilize, working with people who are high utilizers or with chronic conditions. That because they can round with physicians, they can walk into the ED while someone was there. They can be called in to a clinic visit and that kind of thing for warm handoffs. And AmeriGroup, in fact, sees value in that and wants to support that. The other 2 are still ruminating on that.
Sure. Okay. Excellent. We're going to talk about the importance of negotiating for that infrastructure in a second. But I think you're dead on. I think it's really important to be in negotiations with managed care in situations like this, because, and I'm going to move to it because I think it's worth putting this concept on the table. One of the primary reasons that states look to private managed care, particularly the national managed care entities, to come into their market and serve a larger percentage of the Medicaid population, really has to do with the fact that their budgets are strapped, and when managed care companies bid to provide these services, they're essentially bidding to bring an existing infrastructure into that state and into that market. So from that standpoint, the state is not fronting them the capital to get this off the ground. They need to demonstrate that they're properly capitalized to do that. This creates a huge opportunity, but also a huge risk. These plans are not interested in waiting for the safety net to come around to the idea that they want to be a part of that infrastructure. And given their, really aggressive timelines for being able to implement a health plan in a given market or state, they most of the time will defer to building everything they need themselves. And this includes hiring care coordinators or contracting for telephonic-based care management support. And at the end of the day, they're replicating capability that you either already have or really desire to build within your organizations. That's why we feel it's so critical to be communicating that with these plans as they're building out their models, because they're going to spend the money to do it. They're the ones that have the financial resources. It's not the state. The state's not necessarily looking out for the safety net in this transition, because what they're trying to buy from these managed care plans is a all-inclusive, cost-contained package for delivering it. So when there isn't an infrastructure plan, when there isn't an investment plan in how to get the providers to where they need to be to operate under these new models, the providers, whether safety net or not, it really kind of behooves them to be in those types of conversations with the plans about how they might be a part of that overall approach. Gone are the days where we can kind of wait for managed care companies to issue us a contract, give it a minimal review, and then sign it and send it back. We need to be aggressive. It's been our experience that we need to be aggressive in frankly spelling out exactly what it is we want to do on behalf of these patients, because otherwise we're just not going to lever that money out of the plans. Does that make sense? Okay. In this particular market, there was some existing collaboration, but it was really kind of in a fledgling state, specifically around looking at EHR data and sharing some EHR performance data. And so it was not enough, as you heard earlier, the collection of EHR data, the intermingling of that data with claims data, is a really challenging but really important aspect of how to make this type of reform model ultimately work. So they had something to build on, but it wasn't everything that they essentially needed. And the last element of the environment was that the health systems in this market, and I heard a couple of you already say, that when these kind of trends exist, the health systems tend to be either really aggressive in making it health system centric, or the state's desire is for it to become very health system centric, up to and including someone saying that it's really pushing independent providers to almost having to join health systems. So here is the situation that they were dealing with. The health system-centric models, or hospital-centric health systems, private health systems, really already had robust contracting capabilities. Many of them were already doing this type of contracting with commercial insurers. Some of them even as far as running Medicare Advantage plans, or even Medicaid managed care plans themselves. So that was a strength of theirs, and they were well positioned to basically get into those conversations. They also, and we see a wide variety. We don't always see a real desire on these health systems to get into the Medicaid business in a bigger way. But in some markets, they absolutely have, and they have looked to be much bigger players. One of the examples is actually a very early example in the Massachusetts market, particularly around Boston, where an organization known as Steward Healthcare frankly didn't exist 10 years ago, and really rose to prominence and became a major player in Medicare, Medicaid, and commercial insurance because they saw the expansion of Medicaid as a huge financial opportunity. So that's going to vary state to state, but in this particular state, the systems, the large health systems, were in fact looking to become key players in responding to these changes. And everything around that created competition specifically for providers, where suddenly they were looking to acquire providers, put them on payroll, house them in their facilities, which put a lot of strain on the markets. Can anyone willing to talk about some of the competitive forces they've seen, and whether they've seen, and really what's been the impact of increased competition for the same providers? Workforce is a topic. Yeah, go ahead.
Andy, could you repeat the question?
Sure. The question is I was hoping someone could give some examples of where the market's become much more competitive for providers.
Well, Andy, this is Janice. The ACO model is certainly typical of that kind of competition because they have to have the primary care piece because in our case, we're looking at insurance companies who, start these models and they don't have that provider component. And so, there's real competition amongst the various ACOs in the state to get that provider group or to pick them apart, really. A lot of the FQHCs actually get approached independently for being a part of a network other than what they're currently already in. So there's a lot of vying for providers, at least in our experience.
Right. So let's start the overarching discussion, and I will call on folks if nobody volunteers, but the first question that we pose to you is, given what you just heard, what type of model, a network model, might be most appropriate for addressing this environment?
In our situation in Arizona, we're an FQHC, and we feel that an IPA network model would be the best, or an ACO if our state association were to create one.
Mm-hmm. Yeah, I would tend to agree that, an IPA, clinically integrated with the right to negotiate with these managed care companies, specifically around this age-blind disabled population and how that's going to be paid for, really makes a lot of sense. That's not to say that there aren't potential alternatives to that that might work as well, but that would be kind of an immediate response. Any thoughts on some of the most important internal infrastructure to have in place to address some of these challenges?
Well, I think, and I concur with the comments that were just made, because that's exactly, what we address in terms of either a statewide IPA or an ACO. But specifically, the infrastructure concern is the stuff that we've been talking about. A clinical integration and the analytics piece are vital concerns for us in terms of building that infrastructure.
Yep. So, really specifically, I like to get really specific about the analytics. Something that helps the individual organizations understand which patients are empaneled to them. Oversight for making sure that they're getting paid if they do negotiate some type of member per month care coordination payment, making sure that they get paid according to that empanelment, helping them develop a care coordination model that addresses these needs, being able to train and provide technical assistance on that care coordination model, even going as far as to house within the network some additional care coordination capacity, maybe for those organizations that are participating that are too small to have their own dedicated care coordination. All of that would be critical. And then using the analytics to support those activities are exactly the kind of thing we're seeing organizations do in these particular in terms of these particular situations, these particular market forces. Can anyone? Yeah, go ahead.
This is Beth. I have a question for that example. Since it is, since the project would focus on a type of population, age-blind disabled, but not a geography, could it be a group of providers from all over the state that don't even necessarily share patients or see the same patients?
Absolutely, and I think that's what I was getting at is in order to do this efficiently, regardless of geography, the setting standards, having the tools and the training capability, but not necessarily needing to be very localized or regionalized would make a lot of sense. And I'm actually gonna, one of the things that this group really set out to do, and I'll walk through some of their solution. But one of the things this group really set out to do was to operate in every geographic area of the state. That was what's going to give them the most leverage. That's what was going to make them a very attractive contracting partner. Being integrated allowed them to do that without fear of antitrust concerns. But they essentially made themselves an essential partner for these managed care plans by doing exactly what you just said, focusing on the things that aren't necessarily tied to an individual region within the state, but instead looking at infrastructure and improvements they could make regardless of geography and regardless of the local market. So yeah, absolutely the kind of response we're seeing in these types of examples. I'm going to walk through the solution in a second, but are there any other questions or comments? I want to make sure we get you out on time. This has been a good discussion. Okay. Well, I'm going to just quickly go through what this group did because this is based on a real-life example. The conversation started with a small number of safety net providers. And this group of 5 came together and made a nominal investment really to give them the resources to explore what a network might look like. They set out to determine what their requirements for participation would be, what their contracting goals, at a very high level, what their contracting goals were, and what type of help they would need to build this network and make it self-sustaining. They initiated some exploratory conversations with other safety net providers and received an initial positive response, although at this point they were not looking to expand their membership. They wanted to actually develop this entity a little further before they opened up membership to others. They did in fact create a limited liability company. It had a small board and an opportunity to expand membership, so they were willing to take on additional partners as spelled out in their operating agreement. And they wanted to create 2 tracks. They wanted to create an opportunity for folks to invest in the business, in this new business, or simply participate in it. And those had different financial expectations and requirements. They created an initial participation agreement, even though they didn't have contracts. And this initial participation agreement set an initial slate of standards for participation. So out of the gate, even though they hadn't even attempted to enter the contracting market, they were able to articulate a level of consistency in the type of organizations that they wish to partner with formally through this organization. And at that point, they formally invited some of those other interested safety net organizations to join them, and actually now have 18 safety net organizations operating throughout a statewide geography. Their network, they decided they wanted to have a multi-payer strategy and focus. They didn't see as much value in creating this only to address the age-blind disabled opportunity. They saw it as an opportunity really to address all of their payer sources. So they wanted to seek a care coordination and shared savings contract with each of the Medicaid managed care organizations, in their market. They wished to be a bidder on the age blind disabled RFP, and actually ended up doing that in partnership with one of the managed care organizations that they were now under contract with. They entered the Medicare Shared Savings Program, the ACO program, when that ACO investment model was available, and actually sought and received a $1.5 million investment in that. And then also approached the very small third-party or commercially insured population. They approached those plans really just looking for whatever limited upside they could get in those contracts through pay for performance. But in essence, they had a strategy really focused on each of the four major insurance payer mix that they served, and in doing so had to think of an infrastructure that essentially was responsive and sensitive to all of this. The good news is that addressing these four separate types of contracts or payers didn't really require them to expand drastically the infrastructure that they ultimately needed. They identified a couple of key areas where they needed support. A big one was around data aggregation and performance reporting. They also looked to develop a telehealth program specifically focused on getting access to specialists that were underrepresented in their own employed physician basis. They implemented a care coordination protocol through a software program that really sat on top of that aggregated data. And they assisted their participating organizations in hiring new staff to serve as care coordinators under that age blind disabled program, but also under the Medicare Shared Savings Program. In terms of achieving their goals, they created a good governance structure for providing oversight of performance. They facilitated monthly performance reviews across all business lines, and annually revisited their standards, and in fact increased their standards on an annual basis so that when they go back into the contracting market, they're ever increasing, if you will, their ability to address the concerns and the needs of their payer partners. They developed some clear formulas for how gains were going to be shared, and that included having a vision for reinvesting a portion of their gains in the network. So this group actually said, look, even though the long-term goal is to create more sustained investment in the overall population, in the individual providers, that in the short term they wanted to forego that to really build out the network infrastructure that they needed. And in cases of underperformers, there were clear expectations or requirements for those underperformers to reinvest in their capabilities. So, for example, if the requirement to participate increased from level 2 medical home recognition to level 3, and one of their members had not achieved that recognition, well, then in fact they had to reinvest. They had to take any distributions and invest in getting there, or could face expulsion from the network or individual contracts. They also had an ability on an annual basis to evaluate introducing new members. So once a year they open their books and they bring in organizations that have a demonstrated ability to meet their participation standards, which allows them to grow their revenue even more quickly than negotiating new or better contracts. And then they actually have now dedicated management that really assists their individual participating organizations in day-to-day improvement strategies. So we've already had some of this discussion. I wanted to see in the last couple of minutes that we have, I hope that was enlightening in terms of how some groups have really made this very real and have gotten to the point where they're actually doing this work in partnership with one another. Any questions or comments? Is this something that any of the groups on this phone, on this conference call, anticipate they'll be undertaking over the course of the next several months or year?
Well, Andy, this is Mississippi, and this is so valuable for us because of even though we created a legal entity, as Joseph shared earlier, we were at a standstill, and it's encouraging to me because most of what I see here is exactly what we're doing, or at least we're moving in that direction with some help from others, and meeting with some of the stakeholders here to talk about the waiver and, whether or not they're looking at APMs in any form or fashion with our new bidding process for the MCO. So, I think it's been pretty invaluable for me to gain some, both some affirmation and some direction for the stuff that we're working on here. So thank you very much.
Excellent. Thank you.
And Andy, this is Beth. This is definitely at least a couple steps ahead of where we are here in New Mexico, but this has been a good mental exercise to start thinking this way. So thank you.
Good. Excellent.
And this is New York. I'll add that we are just starting down the path now, and this is just tremendous opportunity for us to learn and to model.
Okay, good. Well, that leaves us with just a minute or two to kind of wrap up this week. A couple things we really need from you folks. You should have received a slide template. Next week, we are going to be asking you to present back to us. A lot of logistical challenges in dealing with that. We're going to be following up with each group individually to make sure everybody's going to be represented in that exercise. But if you have any questions or don't have the instructions, please get in touch with us as soon as possible. It's really going to be a much more, I think, rewarding exercise if everyone puts in the requisite time to make this a success. We do need your slides ahead of time. We have a lot of organizational work to do to get them loaded, and then each group will have an ample opportunity to present back on kind of what they've done with this information in terms of how it's influencing their thinking around the potential for network-related activity in their market. We will get an email reminder out to everyone very shortly, and like I said, we'll be following up with you folks individually. We very much look forward to hearing back from you when we get together next. And with that, I'll turn it back to you. I know it's 1 o'clock, so I won't be offended if some folks have to drop. But if there are any questions, before I do let you go, please use the link that you see below to complete the survey. It's really helpful to us to get some input from you folks. And there are some questions, some follow-up questions in there that we would ask you to answer as well. We got very low response last time, so I'm imploring you to actually utilize the SurveyMonkey link that you see on your screen. And then with that, like I said, I'll open it up if there are any last-minute questions.
Hi, Andy. This is Ellen from New Mexico. This is just an operational question. You said next week's meeting?
I'm sorry. Yeah, it's in 2 weeks.
Okay. You just had me a little nervous there.
Yes. That would make me nervous, too, because we have a lot of work to do, too.
Right. Thank you.
Okay. Well, thank you, folks, and we look forward to speaking to you in 2 weeks, although you will be hearing from us before then.